Garth Gulick, Marion College of Correctional Physicians, and I have the pleasure of introducing Michael Wynn, a neurologist I worked with. I guess it was about 97 in Salem, and then I moved to the east side of the state when I started corrections almost 20 years ago. I got to start working with him again, and now for 3 years he's been working full-time with Oregon Department of Corrections. I think you'll find that he has a knack for talking to primary care doctors and interfacing with them like few neurologists. And with that, I'll turn it over to Dr. Michael Wynn.
Thank you, Garth. Hello, everybody. Thanks for tuning in. If you have questions as we get going, just put them in the chat room, and I'll look at that chat every so often as we go through, but I'll certainly get to it at the end to answer any questions you might have. So yes, my name is Michael Wynn. I did my neurology training at Oregon Health Sciences a few years ago. Before that, though, I was in general practice. I was in the Air Force for 3 years as a general practitioner, which was a extremely important experience for me, educational for me as a person and as a physician. I can't say enough of how that helped me be a better neurologist, to be primary care for a few years. So we're going to talk about headaches because I think all of us see these every day, if certainly multiple times a week. And the title is Months of Same Old, Days of Anxiety. And what I mean by that is most headaches we see are the same old, right? It's the same problems we've seen 1,000 times, the same complaints we've heard 1,000 times. So I hope to give you some ideas, maybe some new ideas of how to better diagnose these and treat them and counsel your patients. And then days of anxiety, because we also know that every so often a patient comes in and you just don't feel right about it. There's something about the history, there's something about that way the patient looks that you're thinking this might be something truly bad. So we're going to go over what are the signs and symptoms that should make you feel that way, and should make you feel like you do need to probably expedite something to the TLC so you can get that MRI sooner than later. And anyway, but finally, I did open my practice about 1997 when Garth was in town. And so I've been around almost as long as Garth, even though I look 10, 15 years older than he does. Life is not fair. So this is how I think we feel, physicians, in the DOC. This is Dante Alighieri. He's lost in the dark wood. He's looking over his shoulder. We feel two ways like this. One, we look at our schedule for the day. We have 12 patients and 8 of them have headaches. And so this is how we feel, just like Dante does. The other way we feel this way, other situation is, again, that one patient comes in and there's something not right about it. And we're looking over our shoulder, afraid that this is going to be a disaster for the patient. So that's how we feel. And I hope to address it so you don't feel that way at the end of this talk. And this is, I think, how the AICs feel, our patients feel. That gentleman there holding his head is Bertrand de Born. He was a 12th century musician, actually, that sowed discord between England and France. So this is the 8th circle of hell. As you may all know, in Dante's Divine Commedia, there are 9 circles, and the lower you go, the worse your sin. And so this is the 8th circle, and these are people that sow division and discord between allies and within communities. So it's rather pertinent for today's world, isn't it? Anyway, that's how I think our headaches feel, just like Bertrand de Born. And the reason he's divided, because as you sow division, so you will be divided throughout all eternity in hell. Anyway, so headaches. We're going to talk about the most common types, prevalence, epidemiology. We'll go through some diagnostic criteria, and of course, treatment and prevention. I hope I have some new things for you. And then, of course, we're going to talk about when to worry. And finally, some rare birds. These rare birds aren't necessarily dangerous headaches, and they are rare, but I think you need to hear about them at least once. And the good news is some of them are eminently treatable. You can really do be immensely beneficial to the patient if you can diagnose some of these rare birds and almost essentially cure their headaches, and they will be eternally grateful. So let's talk about the most common types. I'm going to move this here a little bit. In my experience, it's a mixed headache, some migraine component, some muscle tension type component, and they have a little bit of both. Sometimes the migraines are bubbling to the surface more than the tension types and vice versa. That's, in my experience, the most common type of headache. Officially, the most common type is muscle tension headache. followed by migraine, and then, which is again quite common and sometimes is part of a multifactorial headache syndrome, medication overuse headache. We'll talk about the criteria for that diagnosis. Prevalence. Officially, tension headaches are the most common. Lifetime prevalence in the general population is about 52%. Migraines are the second most, with a lifetime prevalence of about 18%. And then the mixed headache, I don't have exact percentages, but they're just very common. And this all gets to what you need to explain to the patient. I do think, even though in our, it's not, I think, our unique patient population, many of them have agendas, many of them have other ideas of what they want out of things, but I still feel that if you can explain clearly what's going on, some of them really will feel better about the situation. So let's talk about the most common tension type headache. There are comorbid conditions that put people at risk for these. And those top three, I think we can see frequently in our patient population. So point being, treating those conditions will help their headache, as opposed to treating headache. Treating the headache can help those conditions, but those need to be identified and explained to the patient. What is a tension type headache? It's ill-defined, it's heterogeneous, and it's kind of like what it is not more than what it is in terms of symptoms. So it is not a localized pain. It is not throbbing, aggravated by activity, and it's generally not severe. It's that dull, global, I have this headache every day, doc. It's been there for years. They're not beating their head against the wall. It's real, but it's not generally severe. There generally is not nausea or vomiting with a tension headache. There's no light sensitivity or sound sensitivity. And of course, there certainly are not any new or progressive focal deficits. We'll talk about that in a little bit. So you rule all those things out. They've had the headache for 15 years. Here they are in your office. They still have that headache 95% of the time, 99% of the time. That's going to be a tension headache. Some key concepts, though, for all headaches. And you'll see this is blue font. As we go through, anything in blue font, that's the Pearl. That's a take-home message. I thought, well, I'll put this in Pearl font. Well, then you wouldn't be able to see it. So that's why it's blue. So realistic goals. The key thing, this is frankly, I think, what my major contribution is when I do a consult. I set realistic goals for the patient. If someone's had headache for years, you are not going to cure them in just a few weeks, and almost certainly not with a single pill. They just have to be prepared. We're going to work together over the next few months to get ahead of this. So realistic goals are critical. And the biggest reason, most common reason medications fail is the dose is too low, or there hasn't been a long enough trial of the medication. That's the other thing that I guess I justify my existence to the DOC within my consults, is these 2 points. And I make that second point. Patient's been on a low dose, I can't say gabapentin, right? We all get in trouble with that. A low dose Effexor, low dose amitriptyline for 2 weeks, and they're not any better. And so therefore, that medication's failed. No, they have to stay on it. The dose has to be increased gradually. And as I'll repeat myself, they need to be on that medication probably for 2 to 3 months before you can truly say it's not helping. Education is critical. And so we need to tell them that they've got to manage some of these things. Now, grant, in their situation, life situation, these are particularly challenging. Sleep, sometimes there's just not much they can do about getting better sleep. Anxiety clearly is a big issue. But the sedentary lifestyle, I think, can be improved upon fairly easily for many of these patients. They just have to be told that until you start moving more, until you start getting out in the yard whenever you can, these headaches are not going to improve dramatically. And if possible, I'll sometimes say that about sleep. Until you get better sleep, until we get ahead of the anxiety, these headaches are just, it's unlikely we're going to make major improvement in these headaches. Acute treatment, NSAIDs, still, they work, they're great. Tylenol also, there's nothing wrong with using medications. We do not like to use them more than 2 to 3 days a week. Then we can kind of start getting into the medication overuse headache syndrome, which I'll talk about. For prevention, amitriptyline, nortriptyline are certainly reasonable. Remeron, I see that a lot, which is reasonable. Effexor, again, very reasonable. Again, they have to realize they have to stay on that before they might start seeing some reduction in their headache frequency. SSRIs really are no better than placebo. I believe Effexor is an SNRI. Let's talk about migraines a little bit. It's very common. 1 in 4 households have someone with migraine. 12% or so of the total population suffers from migraine. And then 90% of migraine patients have a family history. That can sometimes help with the diagnosis. I always ask, are there headaches in the family? I don't ask, are there migraines in your family? I ask, are there headaches? And if they say, yeah, my mother had headaches for years, twice a month, that was almost certainly a migraine. Thus making it a little more likely that the AIC sitting in front of me is actually having migraines. Here's the prevalence, and you can see that age distribution is, I mean, right in our wheelhouse, right? To diagnose the classification, so there's migraine without aura. You have to have at least 5 attacks that have to last for a number of hours, up to 72 hours. They need to be unilateral, pulsating, moderate to severe, worse with activity. There is nausea and vomiting, or especially photophobia and phonophobia, light and sound sensitivity. I underlined 2, 3, and 7 because they really help me clinch that diagnosis and therefore educate the patient. And you notice those are not intention headaches. Migraine with aura, you have to have 2 attacks. The aura has to be one of those 5 realms: visual, sensory, speech, motor, brainstem. Sometimes they can be very dramatic. We talk about complicated migraine. They can actually mimic a stroke sometimes. The aura has to be gradual onset over 5 minutes. Usually it's fairly brief, lasting less than an hour. 2 or more have to occur. One of those auras needs to be unilateral. So the right arm is tingly and numb. Complete reversibility, which of course you don't necessarily see, unfortunately, with many strokes. And then of course, one symptom is positive. The visual tachopsia, tingling, things like that. Dizziness for brainstem, as a brainstem symptom. And then that aura needs to be followed by, within an hour, by a headache. You can have acephalgic migraines. All they have is auras. That can be a challenge, of course, because that could be a seizure. So they just need that workup before you say, oh, it's just a acephalgic migraine. But they are out there. Those people have to have a seizure workup. Chronic migraine is a specific diagnosis. Over 15 days per month for at least 3 months meets the criteria for chronic migraine. This is in my way. How do I get out of that? Sorry. There we go. Classification, further classification after chronic migraine is, I'd like to just give me a All right. Tension type headaches are milder and they do not have auras. Cluster headaches are very severe. They're brief and they occur in cycles. They have 3 weeks of headaches that are driving them crazy, and then they go away. And then hemicrania continua, these are migraine mimics. They're side-locked. They're always on one side. Migraine might be on our other side. Hemicrania continua is always on one side. It's unremitting, 24/7, and there are dietary and environmental triggers, which are the typical ones that sometimes bother migraines, including caffeine, artificial sweeteners, processed meats, things like that. You can tell them about these, so they may be able to modify their diet somewhat, but it might be an extra challenge. Let's see here. New daily persistent headache is a mimic of a migraine, and this is a specific diagnosis. These patients with new daily persistent headache, it's unremitting, 24/7, and they will tell you it started on Monday, the 3rd of October. They will always tell you, I know the exact day it started. This should raise a little bit of a red flag of, oh, well, is that a bad headache? Is it a tumor, something like that? It could be, and we'll go through some things that can help you discriminate between new daily persistent headache and a headache due to a malignant process. And then medication overuse headache, an extra challenge there, of course, and it's really a case of excessive use of acute treatment medications, not prophylactic treatment medications. Some more mimics. These are secondary headaches that occur due to a process. Of course, post-traumatic. That happens. Our AFPs get in fights, get head injuries more frequently than they should. Vascular causes, they may have a malformation, vascular malformation. High, that is idiopathic intracranial hypertension, or low with a CSF leak, intracranial pressure, ICP, and then various substances and medications. Of course, a mass or an infection, hypothyroid or hyperthyroid can cause headaches. They may have some process in the eyes, ear, nose, and throat region that is causing their headache. So for treatment, for acute treatment, the goals are to return to a headache-free full function within 2 hours. That's our ultimate goal for treating an acute migraine. And you don't want a recurrence for at least 24 hours. The key thing here, again, blue font, must treat early. So many times patients will tell me they want to wait, they want to see if before it gets bad. They don't want to take the medication until it gets bad. That's just not the way to do that. They need to be counseled to take the medication as early as possible. What I've often said is if they wake up one morning and they just feel like the planets aren't lined up right, they just know that something's not quite right, that's actually when they want to try and take that first dose. And then, of course, use an adequate dose. Acute treatment, NSAIDs, as I already mentioned, an NSAID plus an antiemetic. I think all of you are doing that. Neuroleptics and antiemetics can be very helpful. There are just a few mentioned right there as an acute treatment. Triptans, you know, sumatriptan is as good as anything. The other triptans really aren't more effective. So sub-Q probably is problematic. I haven't seen that used. No, not in our population. But oral, 50 to 100 milligrams, often required, not 25. I would start with 50. And then remember, they have to take a second dose. So this is where I tell them a migraine is like a campfire. You've got to put it out all the way. Extra couple of gallons of water on it, right? So they may feel a lot better in an hour or two. They still need to take that dose unless that headache is completely gone. That gets back to that prior slide. Otherwise, it'll just bubble back up again to the surface. Probably know this, just to review, coronary artery disease or risk factors for coronary artery disease, then triptans are contraindicated, should not be used. But you know what? There's little evidence linking serotonin toxicity when you combine a triptan with an SSRI or SNRI. If they're on an SSRI or SNRI for some other reason, you still have migraines, you might want to use a triptan. It's actually pretty darn safe. The pharmacist will always tell us, oh, don't ever do that. But that's done all the time by headache specialty clinics. So some newer medications, and it is way above my pay grade to know what our various facilities can afford to have for the AICs. These, I'm sure, are quite expensive, but the calcitonin gene receptor proteins, the GPANs, the antagonists, CGRP antagonists, are quite effective, up to 70% success rate, which is far and away better than any of the triptans. So ubrogepant, 50 milligrams, you can repeat that. Remegapant, 75. So if you have a real, let's just say, clean, straightforward migraine patient, you've gone through all the other things, they just still are not doing well, this would be a very reasonable option if, you know, TLC approves it. There's a new non-triptan triptan, lasmiditan. It's the first ditan that has been approved. Key thing, it is non-vasoconstrictive. So it's an option for people who have coronary artery disease. It's a serotonin 1F receptor or receptor agonist, not 1B, like all the other triptans. It may cause some dizziness or sedation, but lasmiditan is something to think about if you want to use a newer triptan in a patient with known coronary artery disease. Education is key. They need to be reminded that the migraines are not dangerous. They are miserable, yes, but they're not sustaining brain damage when they have a migraine. Ultimately, there's probably really no cure. I think sometimes people do outgrow them, as it were, but I don't say that very often. They're just something that we're gonna have to deal with over time. And again, the realistic goal is to reduce the frequency, severity, and duration of them, but not really to completely eliminate them. They just need to know that you do not have something that's gonna take them away forever, completely. They need to identify their triggers. We talked about some dietary triggers. Some AICs may be exposed to chemicals, I suppose, and then poor sleep. they need to work on sleep hygiene as best as they can. For prophylaxis now, for daily medications, the key principles are you start using a prophylactic agent when they're having more than 3 headaches per month, or when the acute medications just are not working despite your best efforts, or you find that the AIC is overusing them. Then you need to try to dial back the acute medications and induce or start a prophylactic med. Start low, go slow, increase the dose every 2 weeks. We'll talk about the different medications. An adequate trial of one drug is a long time. And again, they need to be told this up front. We're going to start such and such amitriptyline on you, Effexor, but we're going to have to stay with it for 3 to 4 months before we decide that it's not working at all. They just need to be told that right up front. It's going to take some time to go through these. That's probably again, one of the biggest things I see when I do chart reviews is the medication just wasn't tried long enough. And it's hard. I know they come back to you, they're miserable and feel like you need to do something else. I think it'll be easier for you if they know straight up front, you know what, we're going to stick with this for this amount of time. We're going to gradually increase the dose. So the message is, don't come back to me 2 weeks from now and say that we have to try something else, because we're just not going to do it that way. Depakote is a great medication for migraine prophylaxis. There's a total daily dose. If the woman happens to be pregnant, we just cannot use Depakote for teratogenic effects. So never, you can say never sometimes, and never in pregnancy. If the female is going to be released soon, going back, and she's a woman of childbearing age, I would probably not put her on Depakote. Be aware, men and women have to be advised there may be weight gain on Depakote. Topamax, also a solid choice. There's the dose range. Be careful if they have a history of glaucoma, you should not use Topamax, or have a history of renal dialysis, you should not use Topamax. There's good evidence for beta blockers, of course. We've all used them over the years. They really are no longer considered first line due to the risk of diabetes, weight gain, stroke risk, patients who have aura, believe it or not. And of course, we don't like to use them in patients with reactive airways disease or asthma. There's some good evidence for calcium channel blockers like amlodipine. There's the dose. Fluoxetine can be used. Candesartan is getting quite a bit of use in headache clinics now. Angiotensin receptor blocker in chronic headaches. And then good old memantine, pretty safe, doesn't really cause too many side effects. That's worth a try. And again, with all these different medications, they need to be told at the beginning. We have a lot of options. We're going to work through them very methodically. We're not going to double up or triple up at all. We're going to do one by one, and it's going to take time to work through this. Antidepressants, of course, we talked about depression being a comorbidity, either causing the headaches or making the headaches worse. So amitriptyline and nortriptyline. Feverfew, believe it or not, there's some evidence for feverfew. I don't know if the DOC will provide that. And then vitamin B2 can sometimes reduce the frequency of migraines. Finally, magnesium. I tend to recommend this. Some of you may have seen my notes, because actually I've had some success with it. Nothing works for everybody, but almost no side effects to this. Pretty darn safe, not abusable. So we know that there's a hyperexcitable cortex in migraine patients, and it's been linked to low magnesium levels. So give 200 to 600 milligrams a day, and there's a fairly good chance they'll report fewer migraines. Other newer medications, the anti-calcitonin gene receptor peptide monoclonal antibodies, Erenumab, I'll use their other names, Aimovig, Ajovy, Emgality, and Vyepti. You just wonder how big the committees are that come up with these names. Anyway, they work, and as you can see, they're pretty, just a sub-Q injection monthly or infusion every 3 months, and they have a very good record for reducing frequency of migraines. They are, of course, very expensive. There's your responder rates. That's really better than almost any current PO medication. They're highly target specific, so they have lower or adverse effect profile. So they might cause constipation, nausea, fatigue, but there doesn't be any apparent cardiovascular risk. Long half-life, once a month injection, and then rapid onset. Big difference from pills, right? Benefit seen within the first month as opposed to 3 or 4 months with traditional meds. So there's a lot to be said for these newer medications. I just wish our system could be better so that they didn't have to be so egregiously high priced. And I don't know the price. I'm just quite sure they're expensive. Some new data on diet. There really is not a lot of evidence for dietary benefits. That is something you can eat to make your migraines less frequent. But again, traditionally we avoid high caffeine, nitrates, aged cheeses, the things I talked about earlier. Sometimes caffeine helps migraines. I know that, and so I'll tell them you might try that. Have an extra cup of coffee if you can when you get a migraine. It might work for you. But there really is little evidence for the keto diet, a low gluten diet, low histamine, low fructose, or low sucrose diets. There's just very little good evidence that they reduce the frequency of migraines. Now, this is interesting. Diet higher in omega-3s and low omega-6 diets can reduce migraine frequency, almost on the level to that of CGRPs, which is pretty impressive. So omega-3 and 6s are precursors to oxylipins, and those modulate pain and inflammation. So that's how it's believed that they help. Omega-3s are found in fatty fish, omega-6s and vegetable oils like olive and safflower. You do not want to use canola, sunflower, or walnut because they are actually high in omega-6s. So they should use olive and safflower oils. Now, I'm sure we've all heard about the Mediterranean diet, so this is another reason to use olive oil. But anyway, for now, I realize that our AICs don't have this kind of flexibility in the diet. I put this slide in more just for all of you who are listening today. Any of you who have migraines, you might benefit from that. Medication overuse headache, tough problem, no doubt a tough problem. Certain clinical characteristics, it's the quantity, it's how many headaches you have, not the quality. 15 days per month in a patient with a pre-existing headache disorder, you're getting into the medication overuse headache world. And it usually develops in episodic migraine patients. I tell the patients, you didn't do anything wrong. This just happens. Something works. We gave you medication that works. You're having more migraines, so you take more medication, and then we get into this vicious cycle. So it's a near daily headache. It usually starts in the morning. Our patients are wakened up from sleep with this medication overuse headache. Any location on the head or global, and actually neck pain can be very common. The regular overuse needs to be in the level of 10 or 15 days per month. For over 3 months, they use over 10 days per month. They're using everything other than simple analgesics. In terms of simple analgesics like nonsteroidals, if they're using those 15 days per month, then they're in the realm of medication overuse headache. So the 10 days per month would be triptans, for instance. If they're saying, I just got to have my sumatriptan 11 days a month, they're in the realm of medication overuse headache. And again, why are these important? Because you can say, this is the diagnosis. This is where we found ourselves. We'll help you get out of it. You had the migraines. Now you have this additional headache syndrome on top of it because you meet these criteria. It can be any quality, throbbing, sharp, dull, any headache. Patients do have autonomic symptoms, teary eye, stuffy nose, that type of thing. They're often misdiagnosed as sinus headaches. There are certain risk factors. Do these look familiar to us? Yes, they do. Many of our patients in the DOC system and also certainly on the outside have one or more of these risk factors. Diabetes, interesting as a risk factor. Any history of head injury, and of course, again, for many of our patient population, stressful life events in the last year. So what do we do for these things? We have to achieve pain-free response to episodic migraine is the best way to prevent transformation to medication overuse headache. So, judicious use of NSAIDs, triptans, or a combination of triptans and NSAIDs. Then you start Topamax, you start prophylactic medication, and then you gradually wean the overused medication over 4 to 6 weeks. You tell them about this ahead of time. This is our plan. This is what we're going to do. We're not going to cut you loose and cut you back on your triptan that helps you sometimes. We're going to start something to prophylactically help you and then wean you off the other medications. and then constant reassurance. So really, the idea is to get them off the triptans, get them off the Motrin, believe it or not, clean out the system, as it were, and you can solve this medication overuse headache. Hopefully, the prophylaxis will carry them, and you can very carefully reintroduce judicious triptan use. And there you go. Many observational studies show that if you just reduce the frequency of the acute med use, you'll help them. So 100% wean is ideal. And then, of course, establish a preventive activity program, going back to our thing about being more active. That will help them sleep better, and that, of course, will just help their headaches. So here's a key question, though, in blue font. This question, have to answer this. Is the high use of acute medication causing the worsening, that is medication overuse, or is it more a marker of worsening disease? So do take a few moments when you see them and say, wait, is some underlying process getting worse that I need to think about? Or do they have a new etiology that's going on? People with chronic migraines, unfortunately, do develop tumors. I mean, they do develop these other things. So you just have to kind of run through that quickly in your mind just to check off that box, as it were. Let's move on to cluster headaches. So in some ways, an easier diagnosis. They're unilateral. They last minutes to hours. They don't last 72 hours like migraine. They do have autonomic features: stuffy nose, teary eye. They are sidelocked. They are excruciating. These are the headaches that cause the person to pace in their room. They're agitating, and they're very predictable once they start happening. These are worse than migraines. Acute treatment, sub-Q sumatriptan works. And actually, sumatriptan is the only FDA-approved medication for acute management of cluster headaches. Transitional treatment. So again, they say, you know what, usually they have a sense that this is the diagnosis. Yeah, every few years I go through 2 to 4 weeks of these horrible headaches, and then they go away. And then I'm good for months and months. So if that's the diagnosis and you come into it's starting again, start them on the sumatriptan, and you can do a steroid taper if that's possible for that particular patient. Prednisone 100 milligrams a day for 5 days, and then every 3 days, reduce it in 20 milligram increments. There's preventive treatment. If you know, they sometimes will know the season. They'll say, I think I'm going to be getting into one. You can put them on verapamil. That works. A monoclonal antibody, galcanezumab, works. And then regardless of the med used, use it for 2 weeks past the end of their cluster period. So they know this is a 2-week thing, doc. Fine. Continue the medication for another 2 weeks after their last headache. So when to worry. So our intrepid travelers, this is Geryon, Geryon, the body of a serpent, the tail of a scorpion, and the head of a lion. So he actually takes them down to the lower reaches of Inferno, because he's to the area of the fraud, those who committed fraud. So of course, tumors, intracranial bleeds, aneurysms like this. So I worry if someone comes in and their headaches just started recently. They don't necessarily give you the exact day. They just say, I've never had headaches in the last 2 weeks. They started about 2 weeks ago. Or the onset in middle age kind of perks my ears up. What really gets me ordering the MRI is that they say they're progressive. Now, I know some AICs will say it's worse every single day. I'm going to say that you can tell if it's recent and it is worse. You can usually tell if this is the type of progression that is malignant or new or change in pattern. They've always been this way. Now they're different. And of course, if they have new focal deficits, the deficits I've seen are subtle cranial nerve abnormalities, a subtle seventh with a new headache. And boy, my mouth is drooping more than it was last week. That's just an MRI. You just have to act on that. There are some less localizing deficits that can be equally significant: subtle change in personality, subtle change in cognition, a subtle change in balance in a headache that started 2 or 3 or 4 weeks ago. Of course, if they have a history of trauma, maybe they have a subdural hygroma, or cerebral hematoma that wasn't diagnosed. They have febrile illness or any history of cancer. If the headaches are positional or effort-induced, maybe they are elevated intracranial pressure. The best thing to do, a really thorough H&P. Some things never change. check their vital signs. Do they have a rash significant or suggestive of connective tissue disease? Have they had weight loss? All these things that we all know to do to look for systemic illness. Yes, they have to have an MRI. If the CT is negative, because that's all you could get, but they just have this history that is alarming. You just have to insist on an MRI one way or the other. Don't trust a negative CT. And a chest x-ray, because again, you're thinking about cancer is high on your list of the cause of this. Some rare birds. Paroxysmal hemicrania. These are short attacks, 2 to 30 minutes. They're very severe. They're facial. There's tearing. There's injection. There's nasal congestion, a lot of autonomic features. They can have a lot of these attacks every day. The average is about 11, and they're almost always in the periorbital region. Paroxysmal hemicrania. Why is it important to really tease out that specific history as opposed to some migraine that sometimes they say is around their eye? Because the medication, the fourth bullet there, Indocin works. They're going to think you're the best thing in the world. Indocin works for paroxysmal hemicrania. Again, they're always unilateral. They do not occur at night, like cluster headache, which will maybe wake up a patient. The patient is agitated, though, because they're so severe. But again, give them Indocin, and I can almost guarantee you they are going to get better. Versus short-acting, unilateral neuralgiform headache with conjunctival injection and tearing. So if you really think about that, that's almost like trigeminal neuralgia, right? It's actually also like what I just described, right? There's tearing and it's on one side, it's unilateral. The difference is they just have hundreds of these a day. They have many, many attacks of these a day. They don't come in and say, I have 5 a day. I had 30 of these a day, and they're very short. So it has again, that's it's like trigeminal neuralgia in that it's neuralgia form, cattle prod, bam, bam, bam. That's what this kind of headache is. Shorter duration, but many per day. And Indocin will not help them. So big difference here between this and paroxysmal hemicrania. Indocin just doesn't do anything for these headaches. What can you do for SUNCT? Trilamictal probably is going to help. All right. So that would be what you'd want to do. Don't waste time, your time and theirs, on Indocin. So our intrepid travelers they've gone through Inferno, and now they're at the base of the little mountain of purgatory, and things are going to get better. And that's Statius instructing them about climbing the mountain of purgatory to where they'll eventually get to heaven, as it were. So here's a summary. If there are no worry points, then the diagnosis is almost always going to be migraine, tension, or combination of the two. Education is the cornerstone of treatment. If you don't spend a few minutes educating them and getting them on the same page as you in terms of how long you're going to treat them, how long it takes to go through each medication, you're just going to be frustrated. You need to reassure them that their migraine or their chronic tension headache is not dangerous. They're not sustaining brain damage. And you just need to tell them, we just don't have an easy fix. You've had headaches for 15 years. You've all heard that history. We're not going to turn this around today. They just have to understand that from the get-go. The most common reason for medication failure is the dose is too low or just not used long enough. I should have put that in blue font. Remember sleep. This is for you, since some of you may have headaches, but certainly for them, sleep hygiene is huge. In the neurological literature, there are ever more articles on sleep disorders and the importance of sleep hygiene. For all of us of a certain age, sleep is important for our health as exercise or good diet, really. That's number 2, exercise. I put that in blue font. A bit of a tangent here about exercise. Who likes to exercise? Most people don't, because that doesn't sound very fun. And another obstacle to those of us here today, who I think all of us feel like we should exercise more, probably, and certainly our patients should, is the sense of failure. I'm pretty good about it now, actually. But what happened with me, and this is what I tell my patients now, is when you start, you think, oh, well, you got to do 10 reps, 10 curls, 3 sets of 10. Otherwise, you failed. You didn't do it, right? And a few years ago, I just decided to change my approach and redefine failure. And this is what I tell the patients. If you can just do 2 squats today, you have succeeded because you did it. You succeeded today. So do 2 squats every day or every other day, and then 5 curls. If you do that, pretty soon, I can just about guarantee you're going to do 3. And then you're going to feel a little better about And then you're going to, and that's just the way it works. So redefine failure. Do whatever you can do, and that is success. But just, 5 days a week. And if you don't feel like it, fine, you don't have to do 3 sets, just do 1 set once you get going, right? So redefine failure, anything is successful. And that'll help your lives and your AIC's lives in multiple ways. And then, of course, eliminate triggers back to headaches. Some patients just don't know that if they're using aspartame or whatever sweetener it is, or eat a lot of highly processed meats, that's worsening their headaches. And now we can all be calm and not have to worry anymore, I hope. Is that it? Finally, one thing. The cornerstone of headache management, realistic goals. As I've said, I'll say it again, probably won't eliminate 100% of them. And success is fewer headaches and or less severe headaches. So I think that is it. And I'm going to go up here to the chat. Oh, someone just said. So anyway, if there are questions, please enter them in the chat box. I'll be happy to answer questions. And frankly, I'm also happy to, if you have questions other than headaches that I might be able to give a super quick answer to, I'm happy to do that too. Thank you for your attention.
Thank you so much, Dr. Wynn. That was a nice, effective talk through headaches. Does anybody have any questions on his talk? Or as he said, he'll take questions on neurology in general. We're done a little early.
I talked too fast.
Question, if I may. For the occasional headache and or the occasional migraine, non-pharmaceutical, is the recommendation still acetaminophen, a non-steroidal, and a cup of coffee?
Sure. I start with the easy stuff, and that will work in a lot of patients. That's right.
I mean, for out there in the general world, not necessarily our people, but to me that several years ago, that was the World Health Organization's recommendation for attacking these things.
If you look at the randomized studies, the really good quality studies, Tylenol and Motrin, they work. It's now it's standard of care. Yep.
And then do you consider this non-cure process somewhat like chronic pain, that the goal is to become more functional? And
yeah, thanks, Steve. That's a really good way to put it. I mean, I hate to talk like that. I know I probably sounded too negative because every so often we do see someone, and boy, if they just take it right and they've adjusted their lifestyle, they do great. I mean, they can feel one coming on, they can stop it, and their life is great. But you're right. It's more, I guess I'm going to say living with it, but getting it down to low enough thing that they can be happy with their life and go along things, and they know what to do. I think the key thing is there something they can do? If they feel like there's something they can take control of, they're probably not going to complain too much about having headaches because they know there's a plan. They've got a tool. That's the key thing, I think, to give them that sense of hope and control.
As Garth said, thank you very, very much.
And
Sure.
Dr. Wynn, with the cost of the antibody therapies, is there any data on drugs of 2 different classes, like a calcium channel blocker and a tricyclic together, before you ask for a multi-$1,000 antibody?
Yeah. I don't know of any good data, but I mean, on one hand, you can try that. Of course, if you're going to combine those 2 classes, like you just said, there are all kinds of possible complications depending on what other medications they take and what comorbidities they may have. But I've seen many, many patients on both. But again, it takes discipline on our part to stick with the amitriptyline, gradually increase the dose until they feel better or until they have an adverse effect. It's fine. They have an adverse effect at 100. Okay, fine. We'll back off on it. That's not going to work. But we just have to be very methodical about it.
That's a good, that brings to mind one of the questions. You're saying amitriptyline, the first generations antidepressants, work well, but the SSRIs and the NSRIs do not work. Is that correct?
The SNRIs can work. I think Effexor's an SNRI, isn't it? But the SSRIs are not any better than
SSRIs. But the first generation amitriptyline and its ilk are effective.
Oh, sure. In some patients, it's there are some side effects we all know about, but
Yeah,
they're
weight gain, sleepiness.
yeah. I mean, but it's at a low dose. It's a very reasonable choice.
Yeah.
Okay, thank you very much.
Sure.
As we mentioned, this is recorded, and for members of ACCP qualifies for CME. And Dr. Wynn, thank you very much.
You bet. Thanks, everybody. Good luck.